I will start. So, good evening. Yeah, good evening, friends. A very warm welcome to all of you in my show, the Pundit and Dr. Ritu show. Friends, as all of you know, in this show, I always invite the experts from our own doctor fraternity who are expert and masters in their field and who always believe in the knowledge sharing. So, friends, today also I have invited none other than our very own Dr. Naren Malhotra sir, and I am here your host, Dr. Ritu Santwani from Pune. Friends, today our host doesn't need any special introduction. I think all of you agree with me on this. So, as all of you know, Agra is not only known for the Taj Mahal, but it is known for also for our Naren Malhotra sir on the world map. I can say this very, very proudly. So, sir, a very, very warm welcome to you, sir. So, thank you so much for accepting the invitation. Friends, here, before I start the show, I want to share one very important thing with all of you. This is the incidence of 2013 when I gone to NUHS Singapore for this IVF training. There, the Professor Dang was teaching something, and I answered something. That time, Professor Dang told me, "Yes, I know you all Indians are very brilliant, and I know I can take the name of the Malhotras. They are also very, very brilliant." So means इतना मुझे अच्छा लगा था वो सुनकर कि means सर की पहुंच कहाँ तक है. So sir, very, very warm welcome to you, sir. Sir, before we start this going on the topic, sir, as you are the teacher of teachers, so sir, before starting the show, I want some success mantras from you, sir. What is the source to success of yours?
So everyone asks that question. There is absolutely no special mantra. Only hard work is success. There is no shortcut. If you take a shortcut, you may climb the mountain a little faster, but you'll slip down and fall very fast and very early. So if you want to reach the peak, take the ladder up, climb up, and work hard. Be honest to the patient, be honest to your colleagues, and do the work to your best of your knowledge. See, complications and things come, but you must not cheat anyone, and that is what I believe. And the last thing is, don't run after money.
True.
If you run after money, money will run very fast, and then you will have to also run very fast. So you keep on working, let money run after you, don't run after money. So that is what is my advice to the youngsters, and I hope they follow it. You will surely get success if you follow simple advices.
Thank you so much, sir. Sir, tell me what motivated you to become a doctor and a gynecologist?
Me, gynecologist की story अलग है. Doctor, we are from a doctor family. We are now 4th generation of doctors. My grandfather was one of the only MD and MS in India in 1921. He came from Lahore. So he was he was the Director General of Health Services of Rajasthan. So I grew up, and then my father, and then my mother, and then they were always in practice since 1957, the year I was born. So I just grew up being a doctor, and when I was small, everyone would say, "Kya banoge?" So I would say, "Ladies doctor."
Okay.
So, but that did not happen because in the medical college, in the school, I was an average student, but in the medical college, I worked very hard, and I was in the first 3 toppers. And so I had a choice of getting whatever I wanted for post-graduation because there was no entrance exam. So by that time, we were married, and Jadip class fellows. So we were married during an internship.
Okay.
So I told her, "You become a gynec, I'll become a surgeon, and we'll run the hospital nicely. And I'll get a registrarship on surgery, so we'll have a good pay also, and we'll start off well."
Okay.
But she said, अगर से बनना है तो दोनों gynec बनेंगे, नहीं तो तुम surgeon बनोगे तो मैं फिर. So I think that was the biggest good decision which we both took. And you can see that because we had such an understanding amongst each other, and we did. I think that was my life's best decision. Though passing out from Aligarh as gynec was difficult because of the social structure, religious structure, but then I did pretty okay there also.
Okay. Thank you. Thank you so much, sir. Weber, can we have sir's biography here, please? Before we
Biography
start the
in India is that you have congenital malformation at birth 2 to 5%, that is 6 lakh births per year, and stillbirths 13.6% show congenital malformation. Chromosomal defects about 0.5%, so that's 1 in 1,000, that's about 22,000 per year, Down syndrome, and single gene disorders like DMDA, single, all that. And these are 2006, the only Indian publication. We have a registry now, and that registry shows that majority of them is trisomies 21, and then you have trisomy 18, and then you have trisomy 13, and then of course gonosomes, that is sex chromosome, and other chromosomal aberrations about 11%. So this is how it is broken. Now, when initially in 1929 antenatal care became important, so everyone said, because there was no ultrasound, nothing, so said 41 weeks you diagnose everything. But 2013 Nicolaides inverted the triangle of care, and Nicolaides' hypothesis is that the most important is the first trimester triage, or 12 weeks to diagnose everything, and then you need. Now to this, Nicolaides added on the top the first trimester triage, which he said the fetal medicine specialist should look after, which could be an obstetrician. So you could train yourself into fetal medicine. And then later on they said that you need a maternal medicine specialist, you need a fetal medicine specialist, and you need a maternal medicine specialist after delivery. So in the triangle, we added a penthouse of non-communicable disease screening, pre-pregnancy evaluation. And then of course 11 to 13 weeks, and on the tip of the triangle after delivery, it was the pregnancy-induced complication care. So post-pregnancy evaluation in care. Now let's watch this picture carefully. This is a fetus of about 9.5, 10 weeks. So we must understand where the markers come from, because we say double marker, triple marker. So from the developing placenta, you have HCG, inhibin A, PAP-A. From the liver, fetal liver, you have alpha fetoprotein. From the adrenals, you have unconjugated estriol. And nuchal translucency at the nape of the neck, because the lymph vessels from the brain drain into the thorax via the thoracic duct. So if there is, the thoracic duct is not developed properly, which is seen in trisomy 13, 18, 21, the lymph will accumulate here as a nuchal translucency. If placentation is poor, HCG, inhibin, PAP-A will values will be deranged. If the fetal liver is poor, alpha fetoprotein and adrenals, and these become poor when in trisomy 13, 18, 21. So let's see what we can do. In the first and second trimester, we will do aneuploidy study by ultrasound, by biochemistry, and by cell-free DNA or NIPS. And this can be done in first and second. The anomaly scan is done in first trimester 13 weeks and in second trimester 20 weeks. The preeclampsia scan is done early in pregnancy, 11 weeks, by history, Doppler, biochemistry, and by uterine Doppler. And preterm screening is done by cervical length in the second trimester. So this is what is the whole screening, and it's just not aneuploidies which we think. So screening is a test which will tell us which patients are at risk, and a diagnostic test will diagnose. So what do we do in screening? We can do it before 14 weeks or after 14 weeks. 14 weeks we cannot do anything. So 14th week is a gray zone. Before that, you can do sequential screening from 10 to 13, which is extended first trimester screen, or EFTS as we call it. You can do a contingent screen, that is double marker with nasal bone ductus venosus, and we can do a double marker, and we can do a quadruple screen in the first trimester, or rather a penta screen now, which is also known as extended first trimester screen. The second trimester screening starts from 15th. The quadruple marker, please do not do triple marker because it is not accurate. And 14 weeks, if the pregnancy reports nothing to be done, 15 weeks you do. So I'll give you 5 secrets of how I screen. So first thing is, all pregnancies should be offered a maternal and fetal screen. So you need to offer screening universally. Before screening, give a pre-test non-judgmental counseling. tell them that the screening is not 100%, it has limitations, there are risks, there are benefits, then there are costs. And post-test counseling, you have to again tell them that your screen came negative, but that does not mean that 1% you might not have the disease, you might still get it. Give a lot of patient information leaflets, videos, infographics, all this is available on Google. Just take it out, print it, and keep it in your and please never advise a termination on a screening test only. So what do we screen? We do first trimester double marker and first trimester pentamarker. And you see in the pentamarker, you get a 90% detection rate, which is very, very good. Similarly for preeclampsia and for, so enhanced combined test gives you 90% accuracy. And the pentamarker, the accuracy goes up to about 93% or 90%. So the secret number 2 is the ideal time to screen a fetus is first trimester, 11 to 13 weeks, 6 days. And on this, you do the aneuploidy screen by doing a NIPS or a extended combined test. Don't do both. Anomaly scan, transvaginal, high resolution with color in 3D. Preterm labor prediction, we start at this stage, but we do not take this as a gold standard. The gold standard is cervical length at 20 weeks. And of course, we do a prediction of growth retardation in PIH by PLGF, PAPE, mean arterial pressure, and Dopplers. So this is the secret number 1, how you should divide your screening. The secret number 3 is to strategize your risk. When you get a report, you'll get a report of cutoffs or you get a report of moms. So you have to understand what is the median of medians and what is the cutoff values. The newer cutoff values now are simplified, 1 in 250 risk or less than 1 in 250. But we go by the older ones. If it is high risk, risk is 1 in 100. So out of 199, one patient will turn out to be Downs. If the risk is, that is the meaning of this. Then intermediate risk is 100 to 999 and low risk is 1 in 1000. And the low risk patients should be left alone and only ultrasound should be done. Intermediate risk, you shift yourself to the second trimester quadruple marker and then calculate the risk. While the high risk patients, you do a CVS immediately at 11 weeks or at 14 weeks, schedule them for a late amniocentesis. When you have done the amniocentesis or CVS, then what to do? So what to ask for to the lab? So you can, if you are suspecting 13, 18, 21 X and Y chromosome abnormalities, ask for FISH. You get a report in 5 days and it will only tell you trisomies or monosomies of 13, 18, 21. You can ask for a traditional karyotype, which takes about 28 days with PCR, where the tissue is multiplied and then tested. On a dead tissue, this might be difficult. So missed abortion POCs, sometimes you will not get a traditional PCR. You can ask for a QF PCR, which is a quick PCR, and 7 days reporting for that. We must now probably ask for microarray mainly, if you're not suspecting any Downs now. And this can be for any indication, especially POCs, microarray should be asked. And then if you're suspecting monogene disorders, Sanger sequences, and if we feel that we need to analyze all the genes, then a complete NGS or a whole genome sequencing, whole exome sequencing, and that is what we ask for. My last secret is the screening is mandatory, but the patients have a right to refuse. So if they refuse screening, just note down on the paper that I asked the patient for screening and the patient did not want. It's their choice. And NIPS, which a lot of us are getting confused, is still a screening test, even though it is 99% accurate, but still a screening test. And we also have to remember there are chromosomal anomalies and there are structural anomalies. Chromosomal anomalies can be picked up by screening. Structural anomalies will be picked up by ultrasound at 20 weeks. And structural anomaly could be chromosomally normal. A chromosomally normal patient may not have any. So pre and post test counseling is very important. So this is how we go. First combined test, high risk, intermediate, low risk, and chorion with a sampling, amniocentesis, quadruple marker or NIPS, and low risk just a structural ultrasound. The proposal in India is to do a extended fetal test, integrate the first and second trimester. In the second trimester, you do quadruple test and anomaly, and the risk is 1 in 2 for 50. High risk. And if it is high risk, do an amniocentesis. Low risk, continue the antenatal care. Now, why it is so important to do it timely? Because of our MTP laws. And none of the lab will take your sample at 20 weeks. So you will not be able to do a genetic test after 20 weeks. That's why it has to be done very early. And we will not terminate pregnancies. Once again, I'm telling you, on screening test alone. So the genetic screening protocol, which we propagate from Foxy, from Adbhut Matrita, from our iMums app, from our genetic rainbow mix, is any pregnancy, discuss the test with the patient. Patient accepts, patient does not accept. Does not accept, carry on the routine antenatal care and take a consent non-acceptance. If accepts, then suggest the screening. In the first trimester, suggest combined FTS, EFTS or NIPS, one of them. Then you get low, high or intermediate risk. Low risk, you only need to scan for open neural tube defects at 20 weeks. So you can do an alpha fetoprotein and an ultrasound and structural anomaly. High risk, immediately taken for CVS and ask for a karyotype, QFPCR or a microarray. Intermediate risk, you can do the next screening test of NIPS or go to the second trimester quadruple marker. If it is second trimester, patient reports a second trimester, you have two options only, quadruple mark screening or NIPS. And depending on that, we will do an amniocentesis. So now last slide, let us see. On the anomalies, you have 5% environmental, 25% chromosomal, 20% single gene disorders, and 50% complex anomalies. Let's see what test will pick up what. So if I do NIPS, combined test or other screening first trimester, it picks up about 70% of chromosomal aberration, 80%. That's what I told you, 80 to 90%. If I do a CVS and amniocentesis, it picks up all the chromosomal anomalies and about half of the single gene defect. You still miss with this, the others. If I do a very good ultrasound at 11 weeks and again at 20 weeks, it picks up all of them. Or it tells us the risk of chromosomal, environmental, single gene, complex anomalies. So more clinical information is obtained by a very good ultrasound, including 3D, than only doing a molecular genetic technology. So all the tests have to be integrated. So it's not a single test which we are going to go by and we're going to integrate it. So thank you.
Doctors have joined. Dr. Kini has joined from UK. He's saying hello to both of us. And yeah, and when Dr. Shashi has joined from Kuwait. Yeah, welcome, doctor. Sir, the one question by Dr. Manjeet Madam is asking, what is your opinion on NIPT and NUPLID testing for all? Will it ever replace biochemical testing?
So, Dr. Manjeet, you only answered this question for me when I asked once. But yes, I see that, and probably next year the biochemical testing might be out, the double markers and the triple markers and the quadruple, and it will only be NIPS and extended NIPS. And somehow, if we are able to, from that fetal cells, do a complete genome study, so it might even replace the amniocentesis, and I see that also in the future. So if with the NIPS is what? You collect fetal cells from maternal blood. And when you collect fetal cells, right now we do only 13, 18, 21, X and Y. So it's like fish. But now we are getting extended NIPS. So you do that 16 chromosomes, common disorders. But if we can, Dr. Manjeet, Genesis, if you can give us a complete genome study or a Sanger sequence or a NGS from the NIPS sample, it has replaced amniocentesis also. So it could happen, yes. But I think it will one more year.
Yeah, thank you so much, sir. Sir, Dr. Shanti has joined from Texas. Madam is saying thank you. Yeah, Dr. Manjeet Madam is writing something. Yeah. Meanwhile, these questions are coming. Sir, can I ask you one question on a lighter note?
Yes, anything.
Sir, what 3 words describe you? according to you?
I cannot say what describes me. You ask other people. You ask my wife what describes me.
Okay. Okay, sir. Other thing, friends, as all of you know, sir is running a very good Facebook group, Doctors and Food, having a very awesome post in that. Sir, what motivated you to start that group?
See, we feel that the doors of knowledge cannot be closed. You have to propagate knowledge, and you have to propagate complete build up of a. So it's not just education. I mean, we can spend time on just studying books and studying internet. So you have to have. We run a doctors for fitness group. So there you can see there's so many of the doctors who are into such good fitness regimes, and then we run doctors in food, because food is the next thing. It's very healthy. And then this COVID has taught us, actually this doctors in food started with COVID, has taught us all to learn. I've also finally learned how to cook. That is
Okay.
one thing I do not do, because in my family, Dr. Jaideep and Dr. Keshav are the best cooks we have ever known. So they are exotic cooks. Now Niharika also. So I was the only one. Someone has to eat also, now what they cook. But then we made this cook
Okay.
also, and it's doing very well. You see lovely recipes there.
Yes, sir. Acha, sir, regarding Dr. Keshav, I don't know, but for Dr. Niharika and Jaideep ma'am, so I have seen so many times photographs at the time of the Navratri also. Madam is still making lot of prasad in spite of being her very busy schedule. Sir, there's one more question by
Dr.
Dr.
Keshav is the best cook. Dr. Keshav is the best cook in our family.
Okay, great. Ma'am, sir, there is one more question by Dr. Manjeet Mehta, madam. Madam is asking, what concerns are faced by obstetrician in testing for genetic defects in their patients?
See, one, the obstetrician in India are very busy, or they make themselves busy. I don't know, or they propose they are very busy, so they don't counsel. So the counseling part is missing, and just because of that, Dr. Jaideep made this app, iMums, which you all know, and it
Yes,
got
yes.
and we have put all the genetic counseling on the app, so the patient can know what tests she has to get done any month, and the app tells them. So counseling, the doctors, the obstetricians are unable. Then a lot of us are just because we are into obstetrics, or we are into laparoscopy, or into IVF. So the genetics are missing from us. So once you show them a karyotype chromosome, a lot of us get very lost, including me in the initial phase. But then you have to read it and study. Then when the screening test comes positive, and then we fail. तेरा तो NT6 है, abort करा ले. That is the first answer which this thing obstetrician gives, which is not right, because they have to understand that NT is not only genetic; it could be many other curable diseases. So we cannot go on aborting fetuses only on screening tests. So that is what is the major challenge which the obstetricians have.
Yeah. Thank you so much, sir. Sir, Dr. Shanti is asking, how can I screen for autism prenatally? I am a pediatrician, she is writing.
I know, but autism screening is, I don't think we still have. Maybe the single gene Sanger sequence, if we get the sample from the parents and the siblings, maybe because of the, but I don't think we can screen autism. The next question is on pentamarker. Pentamarker is triple marker plus NTNB plus screening for PLGF. So it is same as the double marker with ultrasound. Now pentamarker, if it comes negative, no other test is required except ultrasound at 20 weeks.
Okay.
If it comes high risk, amniocentesis is required. If it comes intermediate risk, then you can go for a NIPS or a quadruple marker.
Yeah. Thank you so much, sir. Vaibhav, is there any questions on the YouTube and Facebook? Can you please paste here? Sir, there is one question on the Facebook by Dr. Vidyashri Kamath. She's writing, can we do, sir, I'm reading, can we do amniocentesis beyond 20 weeks for diagnosing in high-risk patients with structural anomalies? So as to prepare the a long question. So as to prepare the patients at birth about the probable diagnosis and further management.
So now, as I told you, all structural anomalies may not have a genetic disorder. So if it is a major structural anomaly incompatible with life, then it should be terminated and the fetus should have a karyotype. Because 20 weeks is no lab will take your report. Or if they take the report, they'll take it for QF-PCR or for fish. They will not do a karyotype, which takes 1 more month. And 1 more month means that they will cross 24 weeks. And India, abortion is not allowed by 20 weeks and with the court permission for 20. So you have to probably take a permission from the court that you want to do a genetic test. So if it is a major structural anomaly, go straight away and abort the baby and do a fetal karyotype. If it is a minor structural anomaly and you don't see any markers of chromosomal defects, you could probably do an NIPS or if you do an amniocentesis, do a QF-PCR. So you get a report in 7 days before 22 weeks. But after that, it is very difficult to do a test. No lab will take it.
Yeah, thank you so much, sir. Sir, I think with this we have finished up with the questions. There are no more questions. So, sir, thank you. Thank you so much for enlightening all of us and giving your precious time. So, thank you once again, sir. Over to you, Sankalp, or shall I wind off? Sankalp, are you there?
It's a pleasure to be on this, short and sweet, very nice. Carry on the good work.
Thank you so much, sir.
Thank you so much, Doctor. Thank you so much for coming on the show, and it was a very informative and interactive show, Doctor. We from InnovCare Life Sciences, thank you so much once again, Doctor.
Yeah.
Thank you so much. Good night.
Yeah.
So good night, everyone. Good night.
Yeah.
Be safe from corona. That is what we all need to be right now.
Yes, sir. Thank you.
Thank you.
Take precautions.
Yeah. Thank you so much.
Thank you.
Thank you so much. So, friends, with this, we are winding up the show. Stay safe, stay healthy, and join us again on the next week. Next week, again, we are having the two stalwarts with us, the teacher of teachers. Next Saturday, we are having Dr. Hema Divakar Madam with us. And on the next Sunday, we are having Dr. Sunita Tandulvarkar Madam with us. Okay, friends, bye-bye. With this, I am winding off for today. Bye-bye. Stay safe, stay healthy. Thank you to all of you who have joined.